Welcome back, Flash, to the third segment. I want to talk about bioethics, and I think loosely defined bioethics, it's a field of study with healthcare biology, both in human healthcare and how it can also kind of more and also kind of on the animal side of the house, more the veterinarian side of the house. So just ethics in general as it impacts of healthcare, but again driven by biological sciences. And when we talk about bioethics, there's basically four components of bioethics. There's autonomy, there's beneficence, there's non-malfeasance, and there's justice. And you may have heard some of these terms or seen some of these terms in journal articles or healthcare articles and textbooks, but we'll kind of go into them at a little more detail here in a few minutes. So let's just take the first one, autonomy. And from a bioethics perspective, autonomy implies that patients have the right to control outcomes. Healthcare professionals should educate, not dictate. Patients should have informed consent, and the patient's wishes are priority. So let's just kind of take and parse those out. Patients have the right to control outcomes. Remember, I talked in the second segment. Whether it's me or whether it's you, as a patient, you should be able to control the outcome. When we talk about educate, not dictate, again, I don't want a provider that comes in to me and says, okay, here's what I think's wrong, and here's what I expect you to do. I want a provider that comes in to me and says, here's what I think's wrong. We may need to do some diagnostic testing just to make sure that we're on the right track. And once we get that done, we're going to sit down, the two of us, and we're going to outline here are the potential options as far as a treatment protocol. And then at that point, I get to make the decision as the patient. I have the right to control that outcome. Again, I want a healthcare provider that's going to educate. I don't want somebody that's going to dictate to me, somebody that's going to be condescending, somebody's going to talk down to me. And if I have a provider like that, as I said in the second segment, it's not out of the ordinary. Just get up, walk out. Just tell them, doc, this isn't working. I'm going to find somebody else. And also, you want to have an informed consent before the provider actually provides or performs a service. Remember, if they're going to do a complete knee replacement or complete hip replacement, or they're going to do a stent for your heart issues or potential heart issues, you have to give them the consent to do that. You as a patient have to consent to that healthcare provider providing that service for you. And when it talks about patients' wishes are a priority, think about the DNR. Do not resuscitate. If you're in your healthcare proxy, if you've decided that you want that DNR enforced, then the provider, even though they know they can resuscitate you, that's not in your wishes. Again, it goes back to patients have the right to control the outcome. Second one is beneficence. According to bioethics, healthcare providers have to act in the patient's best interest. They have to optimize the health status of the patient. They have to mitigate asymmetric information, and they have to ensure that there are patient-centric treatment options. So go back to performing in the patient's best interest. You have to have the patient's best interest as a healthcare provider. That should be your top priority. Don't get all wound up and in a situation where it's supply reduced demand. You just some slick talking salesman is sold you a new type of technology, and you're trying to make a financial decision on how to maximize that. And that should not be your first priority. Your first priority as a healthcare provider is to ensure that you have your patient's best interest in mind. Again, you want to optimize their health status. As I said before, we're all born with the health status, and it probably improves as we go over time until we hit a certain age, and then that health status starts to deteriorate. Well, as your healthcare provider, you want to ensure that you're optimizing. You want to ensure that you're providing your patient with information that assists them in optimizing that health status. Every step along the way. Don't wait till it starts to deteriorate. You want to be involved, if you can, in the early stages of that managing that health status. You want to mitigate asymmetric information. Again, go back to Errol's article. Asymmetric information and uncertainty is what significantly impacts healthcare goods and services, or the consumption of healthcare goods and services. Unfortunately, asymmetric information is not just on the provider side. Asymmetric information is, as we've seen in the first couple of segments in this module, can also be on the patient side. Patient withholding evidence, patient withholding information, provider not having a complete picture so that they can provide the treatment protocol that's going to optimize the positive outcomes. And then lastly, patient-centric treatment options. Goes back to autonomy, or to me, it goes back to autonomy. You want the patient to have the right to control the outcome. You want the patient to understand the outcomes. I want a provider that's going to sit down with me, and if, let's say the provider comes back with my knee issue, and there are three viable options. I want the provider to be able to sit down with me and explain each of those viable options to me in detail if I want them in detail. I don't want him to be in a hurry to go see the next patient, because he's got to make money on that. He's got to see X number of patients a day, or he's not going to hit his revenue targets. I want that either he or she to sit down with me and talk me through the treatment options and help me establish some probabilities of success so that I can make and it goes back to the autonomy aspect. I can make an informed decision. Non-malfeasance. If beneficence is to act in the patient's best interest, then non-malfeasance is kind of the flip side. Do no harm, either from neglect or misinformation. Now, you might, when it says neglect or misinformation, you might ought to throw another one in there that's just incompetence, because you have a lot of incompetent, or you have what, in my experience, appear to be a lot of healthcare professionals that have not had adequate training. I hate to say they're incompetent. I'll just say that they may not have had adequate healthcare training as they were going through medical school or internship or residency. But you certainly, and that's one issue. But if you've gone through and you've had the proper training, you don't want to neglect your patient. And you certainly want misinformation, either on the patient side or the provider side, to harm the patient as you're developing these treatment protocols. Goes back to when you're sitting in the doctor's office or waiting for the doctor to come in, and the nurse or the clinician or whatever that individual is asking you questions. If they ask you what medications you're on, tell them what medications you're on. The worst thing that can happen, or something that you don't want to happen, is you withhold information about medication. Your provider develops a treatment plan for you and prescribes a medication. And if you go to a pharmacy that hasn't been filling your normal prescriptions, and they don't know about the medication, and you have a drug interaction, that is definitely not something you want as a patient. So you want to control and mitigate that misinformation. You want the provider to focus on the results. And again, focus on the results also ties back into the pharmaceutical interactions. You want a positive treatment plan versus initial pain. And some patients don't understand the uh, process of a positive treatment plan versus the initial pain. So I go in to see my doctor, and my knee is killing me. I can't get up and down the steps. I'm having trouble walking, and the physician, he or she tells me, well, we're not going to. Let's don't get in a hurry and operate, or let's don't try to you know let's don't drain fluid off your knee or anything. Let's try to get you to physical therapy and uh, get you some exercise to see if we can't work through some of that. Now, while that may be a positive treatment plan, it's going to hurt like the devil. And so a lot of patients um, don't want to go that route. A lot of patients, they want instant gratification. They want that pain to go away. And so it's up to the physician to try not to to avoid doing harm to the patients. And it's going to take a physician that understands the um, concern between a positive treatment plan and the initial pain to explain that to the patient in such a way that they agree with them and move forward with the positive treatment plan. And then lastly, we've got justice. You want to treat, and again, we've talked about this earlier in segments 1 and 2. We talk about treat the patients fairly. You want to treat patients fairly. You want to, and equitable, you want to provide equitable care. Equitable care, then, forget about age, sex, social status. You want to treat patients fairly. You want to treat them justly. You want to provide equitable care. Um, you don't want to deny, restrict, um, provide low quality type treatment plans based on patient characteristics. And I'm sure that providers have certain patients. I mean, it would be human nature that if you have a obstinate patient comes in and argues with everything you say and mouths and is just a difficult patient, a provider, to me, it would be human nature to maybe um, not want to provide a positive treatment plan, or maybe not want to provide the best treatment plan to that patient. So I can see that being a difficult situation for a provider. And then you've also got the situation where we're talking about justice. And I think that, and I read in one of the journal articles that I'm reviewing before putting these slides together, patients have a really difficult time, especially maybe not so much in an urgent care, but especially in an emergency room situation where individuals are constantly coming in. They're constantly coming in, they're constantly checking in, they're constantly being triaged, and they're constantly, being sent back out into the waiting room to wait. And so if you have a trauma case comes in, or you have an emergency situation comes in, sometimes individuals sitting in that waiting room don't understand that, well, I've been here 2 hours and that patient just walked in the door. They took them right in and they started providing a treatment plan for them. And that's where it comes down to the emergency and the severity of the issues. And it's up to individuals working in the emergency room to explain that to patients. We had to take that patient in. Please bear with us. It's an emergency situation. They need medical attention right now. And so we had to move them to the front of the line. You've also, on the justice side, you've got administration driven decisions, resource allocation issues. Go back to COVID. In the state of New York, Department of Health decided that that during the COVID issue, they weren't going to perform any elective surgeries. As a patient, if you had an elective surgery scheduled, it wasn't going to happen. All the resources were being allocated to taking care of COVID patients. Sometimes administrative, driven decisions, especially depending on what the financial situation is with the particular provider or provider group or hospital. Those decisions may be driven by financial issues. It could be administrative driven decisions that they decide to close a service. Maybe it's not out of the ordinary, and I've seen it happen recently, fairly frequently, that hospitals are going to discontinue labor and delivery services. They can't staff them. Quality of care is not what it should be. Financially, it's not a viable line of business, and they've just decided that they're not going to provide labor and delivery services. They may decide they're going to close the emergency room. Those are administrative decisions that are driven by financial goals. A lot of individuals, and I had an individual that worked for me in Buffalo during COVID, that his wife went into labor. He took her to the hospital, and they wouldn't even let him in the hospital. They took her in, left him standing outside, and took her at the hospital, delivered the baby. And, he didn't even get in to see the baby until they were ready to take the baby home. And it was difficult for him, difficult for her, but it was a situation where during COVID, administrative driven decisions and resource allocations, and it was just, that was fairly consistent, especially in that Buffalo market. And with that, we're going to kind of pause here, see what else I've got. When I come back for the next segment, and I think we'll probably wind this module up, we're going to talk about ethical importance of healthcare profession. And we'll talk to everybody in a few minutes. Thanks.